Hello, and welcome to the Congressional Hispanic Caucus Institute's 2021 Capitol Hill Briefing Series. I'm Marco Davis, President and CEO of CHCI. This series is the culmination of CHCI's premier 9-month graduate fellowship program, which offers exceptional Latinos unparalleled exposure to hands-on experience in public policy. This unique fellowship program seeks to enhance participants' leadership abilities, strengthen professional skills, and increase the presence of Latinos in public policy areas, specifically in the areas of health, technology, housing, child welfare, and education. CHCI is thrilled to be able to offer our graduate fellows the opportunity to share their perspectives on policy issues they're passionate about and convene leaders in this work for an informative conversation. We would like to thank our Graduate Fellowship Program sponsors for supporting the program, including Facebook, the PepsiCo Foundation, Casey Family Programs, the Walton Family Foundation, Bristol Myers Squibb, DaVita, Wells Fargo, CVS Health, Fresenius Medical Care, and Bank of America. You can keep today's conversation going by using the hashtag CHCIFellows on social media. Please visit chci.org to learn more about our graduate fellowship program, as well as our other leadership programs and special events. And we encourage you to reach out to our fellows via LinkedIn to find out more about their policy topic and help them connect with job opportunities for when their program concludes in May. Enjoy the discussion.
Hi, good afternoon, and welcome to today's session titled Medical Legal Partnerships, Embedding Legal Services Within Health Organizations to Improve Health Outcomes. Today's discussion will highlight the importance of integrating lawyers into healthcare settings to help clinicians, case managers, and social workers address structural problems at the root of many health inequities. Moderating today's conversation will be Isrrael Garcia, Jr., CHCI's current DaVita Graduate Health Fellow. He has spent the past year supporting Congresswoman Lucille Roybal-Allard's legislative team on health, education, and labor issues. Prior to joining the fellowship, Isrrael received his master's in public health while working as a Department of Justice accredited representative at one of the first immigrant-focused medical legal partnerships in the country. This ensured that immigrants had access to free legal services and received equitable health care. He's joined today by a unique panel that will provide valuable insight, stories, and experiences. Once again, thank you for joining us, and thank you to everyone on the panel for your continued work in medical legal partnerships. When we increase access to health and legal services, we improve public health, strengthen our communities, and protect our most vulnerable. With that, Isrrael will get us started. Thank you.
Thank you, Marie, for the warm introduction. Welcome, everybody, to today's final health session of the CHCI Capitol Hill Series briefings. I'd like to start off by thanking the Congressional Hispanic Caucus Institute for this opportunity, but especially thank you all for joining today's conversation as we discuss the importance of ensuring legal access within our healthcare centers to help our low-income community members through medical legal partnerships, MLPs. MLPs are collaborative interventions that embed legal service professionals in healthcare settings to address complex social and environmental concerns. Here, medical and legal professionals serve complementary and reinforcing roles in addressing patient well-being. Health-related social problems may be entrenched in federal, state, and local policies that require a legal expert. The lack of consistent and accessible legal assistance within the healthcare system could impede a patient's treatment or recovery. To tackle the social and legal problems, an MLP can create the right workforce and disrupt the cycle of remaining in unhealthy or uncertain conditions that could impact the health of an individual. Before my opportunity here in Washington, D.C. with the Congressional Hispanic Caucus Institute, I worked at one of the first immigrant-focused medical legal partnerships in the country with the Immigrant Legal Center, an affiliate of the Justice for Our Neighbors Network in Omaha, Nebraska. Within 3 years of establishing the program, our legal team had formed partnerships with Omaha's Children's Hospital, One World Community Health Center, and Nebraska Medicine. Here, each partnership represented a different health system, but also a different client base. One, We worked with the pediatric-focused hospital where the partnership mainly served immigrant parents by answering questions related to their U.S. citizen children's use of public benefits. We also worked with the federally qualified health center where our partnership focused on answering immigration-related questions and identifying forms of relief for our children and adults. Third, we worked with an academic medical center with community-based primary care clinics where the partnership served patients from every department and division, answering questions related to both immigration and public benefits. This unique immigrant-focused MLP bridged the gap in the delivery of services by providing well-rounded care to families who, on top of other social determinants of health, were fearful of possible immigration enforcement if eligible household members access mean-tested benefits like Medicaid, Social Security, SNAP, temporary assistance for needy families, Head Start, or even WIC. Omaha's immigrant-focused MLP assisted healthcare and legal service providers understand the issues that immigrants are facing, fostered interprofessional collaboration, reduced barriers and delays to needed services, and prioritized the health and social well-being of this underserved and vulnerable population. In 2019, MLPs across the country helped more than 75,000 patients resolve legal issues that were impeding good health, trained more than 11,000 healthcare providers to better understand and screen patients for health-related social and legal needs, and engaged in clinic and policy-level projects designed to improve health and health equity for our communities. Research has shown that 60% of a person's health is determined by outside social factors like income, housing, education and employment, veteran status, immigration status, and personal and family stability. The United States spends significantly more on healthcare, more than any other developed country in the world, yet continues to have worse health outcomes. Our country focuses on medical intervention while largely ignoring preventive interventions. These poor health outcomes aren't the result of spending too little, instead are the result of where the money is being allocated. With more than 450 MLPs established nationwide, we will hear from our panel about what makes an MLP, what it can look like, who they can serve, and hear their challenges and successes. Joining us today for our conversation are our esteemed panelists, Bethany Hamilton, Dr. Carrie Rodabaugh, and Ann Mangiamelli. I invite you all in the audience to submit your questions in the chat feature, as we will address those later in the program. Feel free to join the conversation on social media using hashtag CHCI-MLP. I'll go ahead and introduce our first panelist. First, I'd like to introduce Bethany Hamilton. She is the co-director of the National Center for Medical Legal Partnership at the Milken Institute School of Public Health in Washington, D.C. The National Center for Medical Legal Partnership leads education, research, and technical assistance efforts to help every health organization in the United States leverage legal services as a standard part of the way they respond to social needs. Bethany is an attorney who earned her degree from the University of Pittsburgh School of Law and has spent her career working at the intersection of health equity and social justice. She most recently served as Deputy Director of State Affairs at the National Association of Community Health Centers, where she led projects focused on expanding Medicaid, defending the Affordable Care Act, and strengthening the ability of community health centers to carry out their mission. In her current role at the National Center for Medical Legal Partnership, Bethany brings her unique understanding of healthcare and legal service operations to use MLPs as a vehicle to help dismantle these systemic inequities. Thank you, Bethany, for joining us today and for representing the National Center for Medical Legal Partnership. Take it away.
Thank you so much, Isrrael, and thank you for the work that you did on the ground to really help us continue to find these opportunities to be able to elevate medical legal partnership as an approach and a model that works. So I have a few slides to share, do a little bit more level setting. Isrrael did a great job talking about what the National Center does and also what medical legal partnership really is. I'm going to do a little bit of more deep dive into SDOH work, or the social determinants of health, to talk about how medical legal partnerships really are that upstream intervention to be able to address the social determinants of health. So on the next slide, this is what Isrrael was talking about. You heard Isrrael quote or use a percentage that I often go back to, which was 60%. And I've seen updated research that goes all the way up to 90%. So some of you may be out there seeing the research where we are finding more and more every day that a person's health is determined a lot more by those conditions in which they live, the environment, where they work, where they play, where they learn, those things that the World Health Organization talked about and called the social determinants of health. So right now, what we're quoting is anywhere from 60 to 90% of a person's health really is determined by those social factors. And many of those social factors actually translate to social needs that are legal needs that can be addressed through legal interventions, through commonly civil legal services attorneys that work at organizations around the country. Some of those lawyers are not just a civil legal services organization. Some of them are pro bono attorneys. Some of them are law students and law schools that get involved in medical legal partnership. So it looks a little different around the country. And what I'm trying to get across is this approach is pretty flexible. And I'll talk about what it looks like in a few examples, but you'll certainly hear from Nebraska how they carry this out on the ground. But I want to just talk a little bit about what civil legal services problems, using this slide very quickly, really pop up when a physician or clinical provider or an intake person in a healthcare setting may interact with a patient that turns them into a client in need of civil legal services. So you'll see on the right-hand side of the screen, we have what we called our iHelp chart. And those are some examples. And I hope you all will go back and say, I help, and MLP after you leave this presentation today, because that's a quick and easy way to really recall what we're talking about here. So what does iHelp stand for? We're talking about those income or insurance issues, those housing or utility issues that we saw play out, for example, in Texas, or employment barriers, such as the unemployment crisis that's playing out right now, or education or legal status, some of what Isrrael worked on with the immigrant populations in Nebraska, and then keep carrying that out. The P, more personal or family stability issues. Here's the problem, though. LSC in 2017 did a justice gap report where they identified civil legal problems for which there just wasn't enough in the legal bucket to be able to address all of the problems. So civil legal problems actually related to health and consumer finance issues were found to affect more households than any other type of issue. So this is an opportunity that I just want to highlight, right, for everyone listening in today to understand that medical legal partnerships are the intervention and approach, but we have different systems at play here and a whole lot of need. And if you're trying to figure out how do I identify the need, how do I talk about it, that's why I highlighted the iHelp chart. All right, so next slide, I'm going to now tell you what can you use as a standard definition. I actually think Isrrael did an excellent job providing you with a definition. But if you want to quickly just tell folks what is a medical legal partnership, because I've been there before talking about it and people are like, what's that? Is it compliance? Is it this adversarial nature? Yeah, I need a compliance attorney. Oh my gosh, am I being sued? Not quite. When we talk about medical legal partnerships, we are talking about what Isrrael explained, which is the intervention where your legal and healthcare professionals really collaborate. They join forces, right, in this cultural shift to really be able to help patients and patient populations in these communities resolve their social, economic, and environmental factors. In other words, the social determinants of health that really contribute to the health disparities and may have that remedy in civil law. Okay, next slide. What do they do? Once you've embedded a lawyer, really integrated the legal services, not just the lawyers, but also your paralegals and your intake specialists and your social workers who stand in between these spaces. Once you've done that embedding and integration, medical legal partnerships aren't just doing the direct legal assistance to really make those patients healthier, but they also are doing work in the training space. They're doing work to address clinical level changes, and then they're also going all the way upstream to address policy level changes that can really help to strengthen not just the healthcare workforce, and I just highlighted health centers here for an example. I'll show you why in a second, but also get to that greater goal of improving health equity. Okay, next slide. what does this look like? Sometimes it helps to understand exactly what this looks like in a community. And one of the quickest examples, and I like that this one highlights the food desert, because many of you may have known the late Dr. Jack Geiger, one of the founders of the community health center movement, where he, back in the 60s, was in Mount Bayou and recognized that some of the health concerns that were playing out for patients presenting to him were really in need of a prescription for food, right? There's only so much you can do. You can prescribe medicine. You can even like tell that person all of the healthy actions they can take. But at the end of the day, the real intervention was prescribing food. And he actually worked with a lawyer in the community to help to address the health inequities. So one of the ways to look at this, and in terms of like where do legal services fit within the healthcare organization's response to social determinants of health, is think about being in an area with a food desert. This is where someone is presenting, you have an entire community, perhaps they don't have access to that supermarket or the healthy foods. That results in a social need, right? Of families or an individual who might be isolated, such as our older adult communities, they might be in need of that fresh produce to control for some sort of chronic condition, such as diabetes or hypertension. Keep carrying that down the road, right? All the way to what is the actual legal intervention that can play out at the individual level. Perhaps that family is low income, and what they really need is not just information, but maybe they've already applied for something like SNAP benefits and have been wrongfully denied. And that's where a lawyer or that legal need can be addressed using civil legal services. On the next slide, taking it from the individual level, I want to share with you all that, just like we showed on that pizza pie slice chart that I displayed before, that the medical legal partnerships around the country are not just tackling those individual needs, but we really like to show off that this approach goes way into the policy level changes that can affect entire communities and improve population health. And MLPs really are one of the only interventions, and it is because it is a partnership-based approach. It is because we're helping all of the different providers practice at the top of their licensure level, right? And have an actual intervention to tap into. That's why we really show off that this is not just about individual level approaches and interventions. This is going all the way up to the policy level, systemic changes that can really address the health inequities that continue to play out. And we saw as a result of COVID-19 in particular. Okay, so I'm going to highlight very, very quickly what iHelp looks like in case you're wondering. All right, so we looked at what happened in COVID-19 on the next slide. Switch here. There we go. You'll see it's not, this is the way the lawyers can help in each area of social need. Quickly go to the pie chart to show you where this plays out. We are, and I talked about health centers, our folks from Nebraska will talk and highlight some hospital and health systems based approaches. But there are over 450 health organizations around the country who are currently carrying out medical legal partnership models. Let me just note here that this number does not represent folks who are currently considering or even going to be implementing or growing or advancing their or multiplying their medical legal partnerships from within currently existing partnerships. You all may have seen in January of this year some great legislation that was passed that will allow the VA to really grow through some grants their medical legal partnership model. And so if you want more information, I can certainly, Isrrael, I believe we can share some information with folks to better learn about how you can implement these models in the different healthcare systems. What this pie chart represents is the flexibility of the approach as demonstrated through how many different types of healthcare entities they've been able to launch in. And finally, speaking of launching, on the next and final slide, because I want to make sure there's enough time, not just for our colleagues, but also questions. So please feel free to go ahead and type your questions into the comment box. We're looking and we're happy to answer. What you're probably wondering, though, is like, exactly how does this work, right? Do medical legal partnerships need to hire a lawyer directly? Do they need to, or can they partner out? And then I also mentioned, right, the social services community or community health workers, right, who work in between team, they look very different. Again, this goes to my point of the approach, the intervention being very successful because it is so flexible. You can have a referral network set up. You can have some coordinating staff in between that legal partner and that healthcare partner. And you can also have it all baked within and fully integrated, where you have both health and legal all under the same entity, under the same roof, to be able to quickly, in any one of these contexts, really be able to quickly identify, and then be able to address those health harming legal needs of your patient populations. With that, I'm going to stop so that you can see and hear more from friends in Nebraska about what this really looks like in implementation and impact and successes on the ground. And thank you, Isrrael.
Yeah. Thank you, Bethany, for giving us an in-depth overview of MLPs and explaining how legal services fit within healthcare organizations in response to social determinants of health. Our second panelist, Dr. Carrie Rodabaugh, is the director of the Gynecologic Oncology Division and the director and champion of the Medical Legal Partnership at Nebraska Medicine in Omaha, Nebraska. Nebraska Medicine is the state's largest hospital and has been recognized as one of the 100 greatest hospitals in the country. Dr. Rodabaugh studied medicine and completed her residency at Duke University and completed a fellowship at Harvard Medical School. While working in New York, she morphed an MLP that provided free legal services to indigent patients and was later recruited by Nebraska Medicine with the opportunity to establish an MLP. Since then, the partnership has grown and has expanded to cover multiple services, caring for patients with serious illnesses within a network of more than 1,000 doctors and nearly 40 specialty and primary care health centers. Thank you, Dr. Rodabaugh, for joining us today to speak on your MLP experience from within the medical sector. Take it away.
Okay, well, thank you for that wonderful introduction. I want to thank you for the opportunity to participate in this panel because MLPs, medical legal partnerships, are absolutely my passion, and I'm happy to spread the word to anybody that will listen. So can I have my first slide? I just have a couple of slides. This is just a cartoon that really emphasizes, from my perspective as the physician part of this team, and I can't overstate enough what a team effort this is, but this is just a pediatrician with a very quick, simple well child check, looking in at somebody that's had an ear infection and says, that ear is better. Anything else going on? Next slide. And here's the poor mom in the background with every problem you can imagine in the world. And those are the real issues that we need to address. You know, her food insecurity. How is she going to pay her rent? How is she going to keep her kid in school? Unemployment with the recent COVID pandemic. This just really, as physicians, we have 20 minutes for each patient encounter. Myself as an oncologist dealing with exceptionally complex medical issues, but I know that all of these other issues are in the background, and we just don't really have time to address them. And that's where an MLP can really just be helpful. Just a little bit about my story of how I got involved in MLPs. My very first position, faculty position, was at the University of Missouri, coming out as a brand new GYN oncologist. What I do is take care of women with cancer, and with GYN cancers, obviously. So I do surgery, I do chemotherapy. I'm also hospice trained, so I do my own end of life care. And all of this is just completely all consuming. And in my very first position, I found myself with many patients who were diagnosed with recurrent cervical cancer. When a woman gets that diagnosis, generally it is a terminal illness. And these women were often young and very frequently were single parents of very young children. And it just devastated me that I wasn't able to, that was their only concern. They didn't have, they didn't know how to address that part of their care. All they worried about was what was going to happen to their children after their death. And as a young physician, I did not have an answer for that. So I reached out to the law school at the University of Missouri, and we formed a partnership there where our main focus was working on legislative policy, trying to update guardianship laws. And that was really educational for me as a physician to learn how you get a bill through the legislature very, very slowly. And we worked on it for quite some time. When I transitioned to my next faculty position at Roswell Park Cancer Institute in Buffalo, New York, I really thought, how can I make a difference in an individual patient's life? And, I really still wanted to work on all these big policy issues, but being a surgeon with instant gratification in my background, I wasn't getting the quick answers that I needed from legislation. So I turned to attorneys that would partner with me to provide individual care to the patients. And as a physician, I cannot begin to tell you how gratifying it is to be able to help someone with a problem that they have that nobody's ever even listened to. My patients see lots of doctors, and we're addressing their pain, we're addressing their nausea, but nobody's trying to help them figure out what about their living situation. And as a physician, it's very difficult to realize you can't fix everything. And so obviously I understood that very early on, and I turned to my attorney colleagues who can help me fix these problems for my patients. So when I was being recruited to the University of Nebraska, I very definitely wanted to incorporate the medical legal partnership into my new practice. And as part of my recruitment, they agreed to pay for the partnership. And I had to spend a lot of time talking with hospital administration, first of all, to educate them what is a medical legal partnership, how can it help their hospital. So lots of conversations around those kind of issues. And then initially they agreed to fund me for $25,000 a year to start a partnership at my new position. I partnered with Legal Aid of Nebraska, and they threw in kind to 100%. So we had $50,000, which unfortunately is almost one full FTE of an attorney. So we could get an attorney to help care for our patients. And if I can have my next slide, please. So what we did was evaluate the patients that we were able to assist, and knowing that the hospital cared about the return on their investment, we calculated certain cases that we were able to institute benefits for the patient that they had previously been declined. And so the assumption here is that if the attorney had not been involved, then none of the care would have been paid for. So these are cases where we've gotten Medicare or Medicaid reinstituted where it had previously been declined, and making the assumption that if we hadn't done that, all of the care the hospital had provided would be charity care. So on this graph that starts in 2009, the blue line is the financial contribution from the hospital. So we originally started out at $25,000 a year. The orange line is the total number of charges that we charged to those patients. The gray bar is what the hospital actually got back. And then the yellow bar is the difference in that. And that's how much extra return on investment that the hospital made. And you can see that over the years, that return on investment has just grown and grown. And eventually I was able to go to the hospital and say, look, we're getting a great return on investment. Can you please agree to up your investment into the program? And we now have a budget of $297,000 that the hospital funds that we can pay for our attorneys. And what this has allowed me to do is I no longer need to write grants to fund this program. So I have more time to focus on my own patient care and time to focus on the medical legal partnership. My biggest role as the medical champion of the partnership is really to spread the word to the administration, to make sure that they understand all of the good responses that we're getting, the good work that we're doing. My biggest selling point to them when I'm having these kinds of conversations is no longer the return on investment, because that only represents maybe 20% of the patients that we care for. The vast majority of patients, it's just we're helping the patient. And with some excellent stories of, we've gotten one recent story that we had was a patient of mine that was, she was in a coma from her cancer and was in a coma for probably almost 2 years. And she was a young woman. So while she was in a coma, her mother had power of attorney over her. Eventually, she recovered, regained all of her function, and was a very healthy 26-year-old, but her mother still had power of attorney over her. And our attorneys had to get involved, reinstated that, took that power of attorney away because the mother did not want to give it up. She wanted to be able to tell the adult daughter where she could live and who she could marry. The patient got her own competency back and have had recent updates that she's moved out of state, gotten married, and is now a young parent. And it's just heartwarming. So I think that with that, I will turn it back over to Isrrael so that we can get Ann on, who actually does all of the good work.
Yeah. Thank you, Dr. Rodabaugh, for speaking on your experience of being a medical champion of MLPs. And also, thank you for working on the front lines as this country continues to battle with COVID-19. Our third panelist, Ann Mangiamelli, joins us from Legal Aid of Nebraska from Omaha, my hometown. She is the managing attorney of the Health, Education, and Law Project and has played a vital role in expanding MLP access for patients across the state. Her program partners with healthcare systems to provide legal services to patients to address the legal needs which inhibit their health. Legal Aid of Nebraska is the only statewide provider of free civil legal services, providing support and to stand side by side with low-income Nebraskans to ensure the fair enforcement of the law. Ann practices in the areas of domestic relations, Social Security disability, Medicaid and Medicare, estate planning, guardianship, and advanced directives. Ann was appointed vice chair to the Advisory Council on Public Guardian for the state of Nebraska. She is an adjunct professor at Creighton University School of Law and serves on the law school's Health Program Board of Advisors. She's been recognized by the state for her work in establishing Nebraska's first MLP. Thank you, Ann, for joining us today and for sharing your experience from the legal sector. I'm sure many in our audience are eager to hear what it's like to establish and to break in within the healthcare system. Take it away.
Thanks, Isrrael. So Dr. Rodabaugh gave a little bit of her background, and I should probably give a little bit of mine. So my father was a surgeon up in South Dakota, and when I was in law school, he would talk to me about how he had patients who he knew should be on disability, who should qualify for disability, and he couldn't help them. As a doctor, he had no idea how to help them. You know, I had no idea back then what a medical legal partnership was. I had no idea what I would end up doing with my career. But the irony that I'm doing this now, knowing from years and years past that that's been an ongoing struggle. So I've been at Legal Aid of Nebraska for a long time. Our first medical legal partnership was with Nebraska Medicine in 2009. And that was my first involvement in doing medical legal partnerships. You know, Carrie mentioned that we had a $25,000 budget, and I was it. I was the only attorney that was doing the work. And we stayed that way until about 2013. And since 2013, Legal Aid of Nebraska's Health Project has expanded about a hospital or healthcare facility per year. We're now in 10 healthcare systems and 15 different hospitals and healthcare systems across the state. We started, most of you probably don't know Nebraska, but we have 2 major cities and the rest of the state is pretty rural. We started in the larger cities and we've moved and begun to move into some of the more rural areas. I have a staff of 10 in addition to myself, and we handle about 2,000 cases a year for folks in all sorts of areas of law that affect patient health. So 2 of the biggest things I would say that I have learned in working with hospitals, once you get them past realizing, that lawyers can be your friend, they really do welcome and they want medical legal partnerships within their organizations. They begin to understand how important it is having a lawyer around to help. But it's the lawyer's job and the law firm's job not to only do the legal work, but to spend time educating the healthcare providers on how to spot legal issues. And it's a continuing process as turnover, just teaching them how to spot those legal issues. It's also your job as an attorney to act as a resource for them. Sometimes it isn't a patient that has a question, but the healthcare provider, the social worker will email me and say, hey, I have this situation going on. I don't think it's somebody I'll refer to you, but what happens here? To serve as a resource, so as Bethany said, they can work to the top of their license so that they're not worried about the legal issues that their patients have. They let you worry about those, but they know that they can refer those over to you. My attorneys, when we aren't in the middle of a pandemic, spend 1 day a week in each of the hospital facilities, meeting with patients in their rooms, sometimes in offices that we have at the hospital, but most of the time they meet with them in their rooms and interacting one-on-one with healthcare staff. And I have found, and my staff has found, that it's that interaction with healthcare staff that really is the vital role in being integrated into those hospitals. We don't just sit in our law firm and they send stuff over to us. We have one-on-one interaction with them, which has changed a little bit because of COVID, and I think we're going to get into that in a little bit. But, the attorneys, and I appreciate that Carrie says that we do the good work. We get the opportunity to work with these patients, to work with physicians, to work with healthcare staff and social workers. And so it really is gratitude on our end that we get that opportunity. So it is a team. It is a team effort to do the work that we do. So I will hand it back to Isrrael and let's get into some questions.
Yeah. Thank you, Anne, for giving a little bit of your perspective. Your work in establishing and sustaining multiple MLPs across the country, both in urban and rural parts, is admirable. Thank you again, and it's great to see you again. Thank you again to all of our panelists. At this point in the program, we're going to begin the Q&A session. So feel free to start submitting your questions in the chat feature below. But before, I'll ask a few set of questions just to kind of get us going. For the sake of time, please address your questions to a specific panelist if you're able to. The COVID-19 pandemic has exacerbated health and economic disparities. Businesses, schools, and hospitals are forced to close or limit entry in order to control or to prevent the spread of the virus. Health centers have been faced with challenges in responding to the pandemic as the focus of medical providers has been the immediate medical needs of their patients. So my question for all the panelists would be, what impact has COVID-19 had on MLPs, and how has the medical sector stayed connected with the legal team now that they're not able to be on site? Dr. Roderball, would you like to start a little bit, and then we can kind of go to Anne?
Sure. I mean, I think that the biggest challenge has been that the medical side is just exhausted. Mm-hmm. And we haven't had as much energy to devote to our outside projects. So it's been a little limiting from that aspect. But our group in Nebraska, we have continued to meet monthly, and I use those monthly meetings just as my self-help to get me back up to, hey, we are doing good stuff instead of just surviving every single day. So that's been the biggest challenge. I think that the medical side is just exhausted. And Anne will probably address this. We're still providing the exact same care, although we're learning how to do it remotely. I think we've got the Zoom meeting down. Everybody's not on mute. And I think that we're still doing really great work.
Anne, would you like to add on to that?
I would. We've been very lucky that we have a good relationship with most of our hospitals, and the only brand new facility that we have is our VA hospital. But the rest of the hospitals, we have formed a relationship with the social workers. So the fact that we haven't been able to be on site has not been that inhibiting. What has been inhibiting is working around COVID in general. Learning things like if you do an advanced directive for an individual, no one can go in the room except for nurses that are on the COVID floor. So if they happen to be a notary, they can notarize the document as you advise the client over the phone. However, paper can't come out of a COVID room. So then you have to have someone scan it via some sort of electronic device. And it's really been not trying to figure out how to stay in touch with our hospital folks, but how to get around those issues of helping patients when we aren't able to go into the hospitals ourselves and when documents can't be removed from the room. So there's been a lot of actual strategy sessions on the phone with different healthcare providers saying, okay, how can we do this or how can we do that so that we can continue to serve patients?
Yeah. Bethany, what has the National Center seen? Have they served as a support for MLPs that are struggling? What is the trend that you were seeing?
Yeah, so at the time when COVID started, I was just wrapping up my, it was beginning of the pandemic, but I was still at the National Association of Community Health Centers and as training and technical assistance partners to the National Center for Medical Legal Partnership. We were all working with health centers and knew and saw that what Anne and Carrie explained in terms of just the practical aspects of serving patients and clients, they had to be addressed. There was a need for PPE. So at the National Center, and I had tracked this because, again, we were training and technical assistance partners, we saw, I think, some of the most creative, innovative strategies quickly, just as fast as COVID revealed everything, everyone moved quickly to try to respond, and I think a collaborative manner. So this is where we saw hospitals, primary care, legal services, social services, food banks, and yada yada, keep going on and on saying, we've got to address this because there are clearly limited resources, and the responses are probably going to be quicker on the ground than at the federal level, right? But there was still that pressure on the federal level to be able to respond. So the National Center quickly moved into providing technical assistance to ensure that legal services providers were taking advantage of telelegal, for example, because that was one of the quickly moving policy changes that we saw. And then also ensuring that because everyone was, there's this momentum to address the social determinants of health, people had the tools that they needed, like the toolkits that were created on how to build MLP. People had those tools ready and available to them to implement these changes, or at least begin the processes.
Lots of firsts over the past couple of months. But I'd also like to touch on a little bit. We've all kind of touched a little bit, right, of an innovative model within the VA. Bethany and Anne, what do we know about veterans' legal needs, and how has the VA responded to that? What solution and impact have MLPs had on the VA overall?
So I can kick off. First, I think, I'll highlight a 2011 directive that the VA put out, having recognized on issues such as substance use disorder, suicide, homelessness, and housing insecurity. The VA realized that, there are a lot of social needs that amount to legal needs with legal interventions. And so with the 2011 directive, at the height of the Great Recession, the last recession that we were in and probably never got out of, they moved to ensure that VAs made space for legal services. And we have since moved from just dedicating or ensuring space is created to then going one step further. Before I talk about that one step further that we just saw in January, and I mentioned that in my main presentation, I want to move to Anne so she can talk about what she's probably seen on the ground as well.
So we knew that there was a need in the VA for veterans to get services, but unlike our hospitals, they're unable to use their federal funding to fund an MLP. They reached out to me, our VA here, we have a very good VA hospital here in Omaha, Nebraska, and about 3 years ago, they reached out to me and said, we know we need lawyers. We know that our patients have needs and we need lawyers. So we spent about 3 years trying to find funding And just this last October, with a very generous grant from, and I'm going to give a plug to the Women Investing in Nebraska, we were given a grant to go into the VA hospital. And so we're seeing many of the same things that we see in our other hospitals with the veterans. And really with the pandemic, a lot of those needs have become worse. Unemployment, mental health issues that are exacerbated by some of the isolation that they have. And those legal issues can really up those mental health exacerbations because they have things that they're stressed about. If you look at numbers, if you talk about veterans and their legal needs, if you are a normal human being like me or you, your chances of becoming homeless, I think, are about 1 in 194. If you're a veteran, they're about 1 in 10. So those are the things that we focus on, is making sure that veterans get the discharge, classification that they are entitled to. Because with a better classification comes better health needs, and they get better, more money coming in with regard to pension. So there's lots of legal needs that are the same as the rest of our patients, but there's a lot of things that are higher in the veteran community because they are at higher risk for a lot of these legal issues.
Sounds like an MLP is a perfect response to that. And I'm glad to hear that Nebraska Legal Aid was able to get into the VA over the past year. So I'm looking forward to see the great things that you and your team will be able to do there. And we have been receiving a bunch of questions. So thank you all for your involvement. We have a question from Karima. How has the efficacy of MLP services been measured over time, specifically with regard to the impact on patients and institutions? Bethany, would you like to take this one over?
Yeah, sure. I'll start. And then I think it's also, this is where it's absolutely helpful to hear from, when you do have folks on the ground who are carrying this out, it's really helpful to hear from them, because the things I quote they come from research, folks in the field who have really looked at, for example, what medical legal partnerships do to help those practitioners on the healthcare side and the legal side better address systemic inequities, but also practice at the top of their license. What we mean by that really is what both Carrie and Ann explained about having, for example, like Ann's father is a surgeon, identifying what are the real problems causing the health issues that continue to go unaddressed. Finally, being able to say, yes, I've set up this complete systemic model where I can now tap into a legal intervention to be able to actually address the problem that's happening. That's what we, in several documents, we show as that food desert example. You can also hear about the Boston Medical Center, folks who really started the earliest example of the true medical legal partnership model, where the child in the pediatric setting continues to show up with the respiratory issues. Come to find out there might be a mold problem that the landlord continues to repeatedly not address, right? That's not something that doctor in that exam room is going to fix. That's really refer the patient out to a legal services provider. And I know there are questions as well that I'm going to try to actually answer all in one fell swoop here, right? So let's say that doctor has the ability to refer to the law school, because maybe they're the law students who are there to help do the intake through a clinic and then address the problem with the landlord, or perhaps they're set up with a medical legal partnership that then goes from law school to then saying, hey, we need the pro bono attorney at the law firm to jump in here, or maybe civil legal services also split some of that up, right? So everyone jumps in and says, we're going to address the individual pediatric patient's needs, which is to get this landlord to finally clean up the mold problem. And maybe they're also looking at a pretty weak policy that's at that municipal level that could be strengthened, and they're weighing in there. And then maybe perhaps this is an entire set of landlords who are just not complying, and they're causing problems with an entire set of patients within the community. Once those legal problems are fixed, what we do see are the results. And I appreciate Karima's question, because she's really asking about all of the different facets of why these partnerships work. But that's when you begin to see, for example, in a hospital, that's where they're able to say, yes, we've addressed quality metrics here, and we've shown that value and improvement in the populations that we're serving. Same thing goes for health centers and otherwise. So I just wanted to attempt to answer a whole bunch of the questions that I know is coming into the chat, right? About can law schools get involved? Absolutely, yes. And I have many more examples of that.
Awesome. Thank you. Thank you. Hopefully we'll be able to use the National Center as a resource and to kind of touch up on that. And I know you have worked and been involved in discussions of establishing MLPs, whether with a traditional law firm or even within a law school. Can you, we had a question submitted of a law student who's interested in getting involved in the MLP world. Can you describe the differences between an MLP housed at a firm versus a law school in terms of resources or support?
Sure, and I'll tell you that yes, a law school absolutely can start a medical legal partnership. In fact, we had a law clerk who is going to school, I think, at Emory University down in Georgia, and he is working with the administration after clerking here for the summer to try and get a medical legal partnership established down in his law school. The difference that I see with law schools establishing medical legal partnerships and legal aids doing it is the volume. So when you're talking about a law school, you know, you have semesters and you have years and you only have a certain amount of law students. And obviously the law students can't do the work without some sort of supervision. So the number of cases that you can do over a period of time at a law school for a semester before then your semester ends and a new group of students come in is smaller than you would be able to do with a law firm. Because like I said, we do about 2,000 cases a year. To me, and I've talked to our local law school about this, the best setup would be for law firms like Legal Aid to team up with law schools so that we can use, in fact, we have 1 or 2 students from our local law school every year that come and clerk with us and work on our MLP. But to be able to team up so that the law students are getting that experience, but then you can continue to have the volume that hospitals need to sustain a medical legal partnership.
Oh, thank you. Lots of questions coming in. Thank you, folks. We have a question with regards to access and support for mental health services. Dr. Rodabaugh, from the medical sector, where does this intervention, where is it identified, and where could we, for example, make this referral to Anne to make sure that we really do screen this patient and provide the services? What services are provided for mental health? And maybe Bethany probably even join in if there are any MLP specific focused on mental health.
So just to briefly answer, I think it's very clear that any patients that have mental health diagnoses are going to have a myriad of other social issues that revolve around their diagnosis of mental illness. So our particular partnership, we were a little concerned about being overwhelmed with taking care of our mental health population, that it would take too many resources away, that we wouldn't have enough legal assistance. So we've gotten into it very slowly. We now have opened a new emergency room specifically for mental health issues, and we are beginning to support them. We support the inpatient services. So there's a lot that attorneys can offer, and a lot of it revolves around homelessness and helping with insurance and disability. I think that that's a big part of the issue.
I couldn't agree more. I'll provide, this is why I like the legislation that was just passed in January for the VA to be able to provide for grants for medical legal partnership. So researchers have found that when MLPs are integrated into VA facilities, this is where you can see the improved, not just like housing and homelessness problems to be addressed, but also clear indicators of improvement in areas related to psychosocial outcomes. So substance use disorders being addressed, and then general mental health across like anxiety disorders and such being addressed. So there's research to show that when you build an MLP, and you can use the VA context and the research that's there to prove this, and there's lots of other examples, and I just want to point people to that, a quick example. You can see improvements in health outcomes related to mental health. And that's in addition to, right, just helping someone gain access to the coverage they need to even access those services, or provide for a setting that someone may trust. If it's not necessarily a healthcare setting, maybe it is that they're more comfortable with some sort of in-between, like social work provider or the like, and then addressing all of the other social terms of health problems that Carrie was mentioning.
Thank you. And we have a really good question for you. We know that MLPs work when they're on site, and form these relationships with medical staff. However, where does that relationship, where is there a line drawn? We have a question talking about attorney access to medical records, and if you have access to EMRs. Can you kind of explain a little bit of what that relationship looks like and how much purview the legal sector has when they're within healthcare centers?
So I know that there are some legal aids that have, and some medical legal partnerships where they do have involvement in the electronic medical record. We don't do that, particularly because our timekeeping system at our office is not HIPAA compliant and can't be made HIPAA compliant. And because we're legal aid, we don't have the funds to do that. So the way that we get around that, and I don't mean get around that in a bad way, but the way that we handle that so that we get records from the client is we have the client sign a HIPAA release on that end, so that any records or anything that we need from the hospital is able to give us because the patient has signed a HIPAA release. On our end, we have a specific release that we have patients or our clients sign that doesn't waive attorney-client privilege, but does give us the basic right to give an update to the hospital that we were able to help the patient and to what extent we were able to help the patient. So we do two-way releases, one so that we can provide information to the hospital and one so that the hospital can provide information to us. And at this point, we haven't needed to get into the EMR. That really has worked very well.
Yeah, thank you. Dr. Rodabaugh, we had a question submitted during registration that focuses on the needs for a specific population for transgender patients. We know that this is a community that's disproportionately impacted by violence, barriers to employment, lower levels of insurance, and increased incidences of behavioral health. Nebraska Medicine's transgender clinic has renowned staff who assist patients navigate the complicated medical and legal sectors as they access gender affirming care. And please feel free to hop in. What barriers do you see with these patients, both on the medical and the legal side? And how can an MLP help address that?
So the first thing that comes to mind when we're dealing with the transgender population is assisting them with their name change. And the thing that I have really learned through working with the MLP here at Nebraska Medicine is it is very state dependent. There are different laws in each state of how to get your name changed on your driver's license or whatever other identification that you have. So I think it's a lot easier in Iowa for the patients that we care for, and that the rules in Nebraska are a little bit different. And so the MLP can really help patients navigate those legal issues, because that's very important to a transgender person to go by their preferred name. And we at Nebraska Medicine have done a lot of work changing our EMR, because it used to be, well, whatever your legal name is, that's what comes up. And we have really changed that to it's a preferred name. We have nicknames. We now know the pronouns for all the patients. So we're raising awareness with our staff to appropriately address that. Other things that MLPs can help the transgender population with is assistance with insurance denial for their affirming care. So whether that's for puberty blockers for children that identify transgender so that they have the time to figure out what they need and get the proper hormonal medication, and for surgical procedures, either doing mastectomies or top bottom surgeries for patients. These are often denied by insurances, and the MLPs can help with some of those denials, because those denials, they're medically necessary to care for the patient, and it's complete discrimination when they are denied, and that's where the MLP can really step in. On a broader level, hospital policy changes to just get the hospital to address the issues of the patients, even more so for our staff, for our employees that may be transgender, just to be more accepting. And because when you're the employer, we are a huge employer, that then lends into, well, that's your source of insurance. So it just comes full circle then. So those are some of the things that the MLP can help with.
Okay, thank you. Anne or Bethany, is there anything you'd like to add?
I just need to stick up for the great state of Nebraska. I think Dr. Rodabaugh has it backwards. I think it's actually Iowa that it's more difficult. And I actually think Nebraska, we here at Legal Aid do name change clinics for folks all the time. But I very rarely get anything where somebody has difficulty. And I do think it's Iowa that is, so I have to stick up for this great state.
Okay. We have a question submitted for you, Anne, regarding Medicaid reimbursement, and maybe kind of explaining a little bit about that. Let me see where it's at. Are there any Medicaid reimbursement programs for civil legal aid addressing social determinants of health?
There aren't in our state that I'm aware of. Nebraska became a state with managed care several years ago. And I've actually talked to them a couple of times about, trying to form a relationship. But at this point, there isn't anything where our MLP or an MLP can get reimbursed from a managed care or a Medicaid organization for the work that we do. It is built within some of their contracts, and I know here in Nebraska that it is, that they specifically address social determinants of health. And so, I think that in the long run, there will be medical legal partnerships that are partnering with more of the managed care organizations because of their specific requirement that they address social determinants of health. And how do you do that better than having a lawyer?
Isrrael, if I could add to that one, I think, it's key. What Anne mentioned there is not necessarily in a state of Nebraska yet, but there may be other states, right, where you can see the example. One of the examples that I quickly point to, and there are several others where they've said, not only are we going to address the social determinants of health, but we are going to identify the specific intervention as well as the provider types, right? In this case, you would have the lawyer as the specialist provider that would be able to address that problem. So I look at Oregon as one of the states with an example as to where they use their managed care arrangements to really highlight, for example, housing, right? And I'm highlighting housing because what are we facing right now? An eviction crisis, right? Housing across the board is something that someone around the country can just easily grasp onto and agree housing is health. So if you look at the state of Oregon and what they've done, and I think NASHP actually did a really great and thorough and comprehensive write-up very recently on how this works in Oregon, how they've looked at housing and actually explicitly mentioned the role that legal services can play to be able to, through medical legal partnerships, address within the Medicaid. So we're talking about Medicaid reimbursement here, right? But using Medicaid finance to be able to support what medical legal partnerships get done. And that's just one example, because again, Nebraska, not yet.
Well, yeah, I think it just shows how one state over, or even one community over, MLPs can differ very, very much. And Dr. Rodabaugh, in your experience, when you moved to Nebraska, you had funding secured. Can you speak on your experience as a champion? Any challenges or pushback that you may have faced or have heard from healthcare executives or from the C-suite, right? What buy-in is needed in order to secure funding or even support for MLPs?
Well, always the very first issue when I'm talking to administration that are not familiar with medical legal partnerships, they are absolutely concerned that we're going to bring attorneys in and we're going to be dealing with a lot of malpractice litigation. And it just takes multiple conversations to reassure them, no, we do not do any malpractice work. I think that it's been a little bit of a challenge to, now that I've been here for several years, the administration has actually turned over a couple of different times. And I'm always completely starting almost from scratch to make people understand, because it's such a foreign issue or concept to the administration, that of the good work that we're doing. And so it's kind of behooves the medical champions to shout it a little bit louder from the rooftops so that people can understand the good work that's happening. But just to get people to understand how much we are helping their patients.
Yeah, thank you for your work. Bethany, we actually have a question submitted in terms of current legislative priorities for MLPs at the federal level. As we've been discussing, Iowa and Nebraska, the Missouri River runs right through it, but they can be completely different in terms of policy. What are some legislative priorities that you've heard about the National Center that our audience members can kind of learn more about?
Yeah, so if we're looking at the federal level, right, I tell everybody, take a look at, how we continue to build on the CARES Act and look at some of the very broad proposals and policy changes that are going to be made through the American Rescue Plan. I keep wanting to call it the American Recovery Plan as if we're back in the recession, Great Recession #1, but the American Rescue Plan. And so, when people say, and I just need to take a step back a little bit and say, when people ask, how do you start an MLP? I can't help but think with an open mind, first of all, with an open mind, right? It's the same thing as Carrie sitting in an exam room and having an open mind as to what's really impacting her patient so that she can refer to Anne for those legal needs. You start with an open mind. So when you look at the legislation that's out there, right, and you think about the social determinants of health, and this is whether you're looking at the federal legislation or opportunities that may be there and existing or already existing, as CMS just reminded everyone through a recent state health officials letter, you look at existing authorities under Medicaid and CHIP, and you can use that to take care of the social, to implement interventions to address the social determinants of health, right? So start with an open mind, use the social determinants of health and say, okay, how are we addressing the needs that we saw show up for our older Americans around the country? How are we addressing the needs to ensure that students, right, who at adolescent age they're falling through the gaps for healthcare, right? So what is it that's causing adolescents, right, from as soon as they hit like 11 to 16 to suddenly miss out on care? Is there some social need that's a legal need, but a legal intervention that you can use to address? And maybe it's that you're addressing school-based health centers. Maybe you're looking at, like the law school where I went to school, they have a health law clinic where the medical legal partnerships focuses on pediatric patients through the children's hospital, right? So maybe that's what you're looking at to see, is there some issue there related to guardianship or otherwise, or is there a family law issue? When you look at veterans, I keep coming back to that, right? Don't just think it's just about a veteran's status as a veteran or accessing those veterans' benefits. There are a host of issues that someone who is a veteran, who's Black, brown, whatever, an immigrant, right? A host of issues that we all share called social determinants of health, housing, substance use disorder, all sorts of issues, hunger, right? Divorces, right? So think with an open mind when you look at any of the opportunities, and I stress not yet for Nebraska, because there are the local level issues, and that's, when you look at the housing crisis, that's very localized in nature, not just at the state level, but jurisdictionally, it very well may be controlled by a municipality, and that's certainly where we can see across the board. Law school students who are hungry to do something, you all are equipped to write things, everything from studies to like drafts or just read the legislation and tell legal aid as well as your medical and healthcare partners exactly what something means. So there was a lot, probably more than was asked, but with an open mind, there are your opportunities.
Yeah. Dr. Rodabaugh or Anne, is there anything else you'd like to add to that question?
I don't think so. I think Bethany got it all.
I'd like to say one more thing. When you're talking about challenges and talking with administration, and I talked about the turnover, and I'm always starting from scratch. Even when I have a high-level administrator that absolutely has drunk our Kool-Aid and understands that I've brought them to the national meetings and they know the value, it's still important for me to understand they still are working with an extremely limited budget. So even if they think this is the most important thing, I may not be their main priority. They're still taking care of an entire hospital system. And so it's kind of behooves me to try to help them raise my priority level. So those are the kind of things that I work on when I'm in the elevator with these folks.
Mm-hmm. And Isrrael, I know everyone's tuned in, right? And we keep saying, right, the legal community is what we're really integrating here. And, if folks really want something more concrete, what Carrie just reminded me of, right, is we've got to fund civil legal services. Yeah. There's only so much like legal aid, as one of our National Center former colleagues used to say. She said there's only so much legal aid in the pharmacy, right, to be able to prescribe. So we do have to think with an open mind about who you can tap with that legal expertise, but we also have to properly resource it. Yeah.
Thank you, Bethany. And we're nearing the end of our program. It's been Great, lively discussion. And before we wrap up today, I'd kind of like to give Anne, Dr. Rodabaugh, and Bethany a chance to kind of give your closing statements, your last message to those in the audience. What would that be? And we'll start with you, Bethany.
Sure, and I'll be very quick. I do say, start with an open mind. But remember, medical legal partnerships are your intervention where you are integrating lawyers to address the social needs that are really legal needs that have health harming effects on patient populations. So we certainly hope you all talk MLP until whoever you're talking to, their ears are ringing MLP. But if you need any additional help, please feel free to go to the National Center for Medical Legal Partnerships website, and don't hesitate to reach out to find out where a medical legal partnership may be in your community or where opportunities exist.
Thank you, Bethany. Dr. Rodabaugh?
So I think, my closing statement is to understand that all patients, particularly patients living in poverty, have multiple legal issues that maybe they haven't even identified. And the medical team probably is not going to have the time to identify that either. So we're working really hard just to get the patients referred so that our legal team can then really assess and address all the issues that a patient might have. But there's a lot of research out there that says, if you identify one legal issue, it's very likely that that patient is going to have 2 to 4 separate legal issues that just have not yet been identified. And those are the things that we need to be helping.
Thank you, Dr. Rodabaugh. Anne?
Okay, so I'm going to finish with a story, because you may be listening to this and thinking, I still don't know what this means. I still don't know what this looks like. What kind of patients need help? So I want to tell you about one of my clients. I often refer to them as patients. I had a client who was disabled, but she wasn't on disability. She had a myriad of things wrong with her, but one of the things that was wrong with her is she had high blood pressure. She couldn't afford her high blood pressure medication, so she wasn't taking it. She had 3 unreimbursed hospitalizations at one of our local hospitals in 1 year, all because of something called high blood pressure crisis, which I didn't know was a thing until I got this case. So we had someone who was hospitalized, unreimbursed to the hospital 3 times because she wasn't taking her blood pressure medication. We were able to get her on disability because, as I said, she was disabled for a number of reasons, not high blood pressure. After she was on disability and was able to then afford her medication, no hospitalizations in the next year. So when you talk about how this helps the patients and how this helps the hospitals, twofold: no more unreimbursed hospitalizations for the patient, and no more hospitalization for a patient who can now afford and take her high blood pressure medication.
Thank you, Anne. And thank you again, Bethany and Dr. Rodabaugh, for joining us from both Washington, D.C. and from my hometown of Omaha. It's great to see you all, for sharing a little bit of your stories, experience, and leadership to those that are interested in learning more about MLPs. Thank you to all in the audience. It was a lively discussion today with so many questions. I highly encourage you folks to reach out to the National Center for Medical Legal Partnership. They have resources on resources and briefs, and even toolkits on how you can get started with your own MLP in your own community. If you wish to continue with the conversation, please do so on social media with hashtag CHCI-MLP, and by also reading and visiting resources included in the chat box below. As our healthcare system continues to evolve, it is important that we explore innovative models that will address systemic issues both at the population and individual level. A public health, healthcare, and public interest goal should be to address social determinants of health to improve health equity. Yet these disciplines continue and frequently work in silos rather than in tandem. Thank you all again. And once again, thank you to the Congressional Hispanic Caucus Institute for gathering us this afternoon. I highly encourage you all in the audience to tune in next week as we continue with our Capitol Hill series briefings. Thank you everybody for being here. Take care and stay healthy.